Let's invite Dr. Parvati, who was the former professor of pediatrics at GMC Trichur and nodal officer at REIC Trichur. Now professor of pediatrics and head of child development center at Amala Institute of Medical Science Trichur. Welcome, Dr. Parvati.
Good afternoon, everyone. First of all, let me thank Dr. Geeta and KSOS for giving me this opportunity to be here to speak at this important workshop. So, as the previous speakers have said, cerebral visual impairment is visual impairment due to a problem in the brain and not in the eye. The child sees, but the child cannot make sense of what he sees. So why is CVI missed? CVI is missed because eye examination is normal. It is often maybe diagnosed in a young child as delayed visual maturation. Once an ocular problem is diagnosed, people may not think beyond this diagnosis. There would be other urgent medical issues like seizures, developmental delay, etc. and the difficulty in examining the child. These are the important factors why we miss CVI. So who sees children with CVI? Of course, the ophthalmologist, but they don't come so frequently to the OPD. Similarly, the pediatrician also, the general pediatrician also doesn't see cases of CVI. These children usually come to the neonatologist when they are in the follow-up clinic, the pediatric neurologist when they come with delayed development of seizures, to the developmental pediatrician. Sometimes they go to the psychiatrist because they may have behavioral changes resembling autism or ADHD. And they are very often picked up by therapists now, the speech therapist, the special educator, optometrist. All these people are more aware of CVI than we are. Now, why is early diagnosis of cerebral visual impairment important? The eye contact develops by 6 weeks of life, and if eye contact has not developed by the age of 8 months, you should consider it as a developmental emergency and look into it. Okay, this is the development of the brain. The brain, only 25% of the brain development is over at birth, and maximum development occurs in the first 2 years of life. You have a large number of neurons and connections, but after the age of 2 years, these connections and synapses come down. So what you have to do is, you have to act early. If visual impairment occurs early in life, it can affect mobility, because children see and learn. It can affect mobility, it can affect communication, it can affect activities of daily living and learning. So you have to pick up CVI very, very early, and you have to start your intervention. This is called habilitation. Before the child develops handicaps, you have to start your visual habilitation. Now, the prevalence of CVI is the studies from India are usually from clinics, specialized ophthalmology clinics, and prevalence is reported to be about 33%, and combined with OVI, it's about 44%. Now, we did a survey of the retrospective analysis of the cases we had seen between August 2018 and May 2020, when we started this Regional Early Intervention Center. Dr. Sujata was speaking about. The center we had a high-risk clinic where we followed up newborns who had moderate to severe problems and were at risk for neurodevelopmental disorders. In 2018, this was upgraded into a Regional Early Intervention Center with a multidisciplinary team. So we did an analysis of the cases we had seen so far, and there were 53 cases. The average age at diagnosis was a little late, 24 months. It should not be so. There were more males than girls, and many of them had ocular problems in association. And of these children, 66% had a birth weight below 2.5 kg, and those who were low birth weights were term babies. So we had more of term, small for gestational age babies than preterm babies. So the risk factors for CVI have already been mentioned. So these are the newborns or the babies who come out of the ICU who are at greatest risk for CVI. So in our study, again, we found that HIV was the most important. Hypoxic ischemic encephalopathy or birth asphyxia was the most important cause, followed by hypoglycemia. Epilepsy. Of these 6 children had seizures, and 3 children, 2 of them had West syndrome and 1 had Dravet syndrome. Meningoencephalitis, hydrocephalus, cortical dysplasia, metabolic disorder, glutaric acid type 2 and a genetic disorder which was a 12p deletion found in a child who was born by IVF. So there is a slightly increased tendency for CVI to occur in children who are born by artificial reproductive techniques. Now, when should a pediatrician suspect CVI? When a child has the above mentioned risk factors for neurodevelopmental disorders, or when a child comes to you with a neurodevelopmental disorder like cerebral palsy or developmental delay, when there are unexplained visual problems, even after correction of vision, the child still, the parent still feels that the child has a visual problem, and when you find abnormal neuroimaging findings in the visual association areas and in the visual pathways. Now, what are the features in different age groups? So, children present in different ways in different age groups. In an infant can present, this is a 2-month-old baby and this is a 5-month-old baby. This 2-month-old baby was brought by the mother with the history that the child was not looking at her face or there was no tracking movements. So what we did was we examined the child was perfectly normal, all other milestones were development and this child was born preterm. So this you can call, this condition is called delayed visual maturation. If all milestones are delayed and the child is preterm, you start habilitation, the child will usually pick up. So this child again brought at the age of 5 months with a history that he was not looking at the mother. So we examined him, showed him a bright object. He was not tracking the object, but the response is when he was shown a rattle, the response was better. He was responding better to auditory stimulation rather than to visual stimulation. The response is obviously better. Again, this is look, when we took the history, this child had an episode of seizures at the on third postnatal day. Seizures which occur on the third postnatal day are usually due to hypoglycemia, and seizures which occur on day 1 are because of hypoxic ischemic encephalopathy. This was the MRI. There was parieto-occipital gliosis extending here more to the parietal area. So this child also had an associated weakness in the upper limb and lower limb. So he had hemiplegic cerebral palsy as well. So when you get a lesion like this, always look for limb movements. Now this is another baby, just as Dr. Sujata said. This baby was also brought with the history that he was not tracking or fixing his vision on any objects. You can see that he's just not looking at it. So this is because the baby had continuous seizures. This is the pattern of the EEG. It's called hypsarrhythmia. When the child has seizures like this, all his developmental domains will be arrested. So once you treat the hypsarrhythmia, the child will start improving. So whatever it is, you start your visual stimulation, visual habilitation, and treat the seizures. Very, very important. Now there are structured questionnaires which will help you to screen infants for CVI, and these are the questionnaires: the short visual skill questionnaire from Ulster University and the Spanish questionnaire by Pio et al. They're very helpful for eliciting the history. Now, how does a toddler present to you? The toddler usually presents with history of delayed milestones. This was a child who came to us suspecting autism. So he wouldn't open his eyes and he would just move around in circles. He had severe impairment. He was not speaking. He wouldn't use his hands for any purposeful movements, and there was no communication at all. So when we took him to the dark room, you have to always check vision in a dark room. He started slowly opening his eyes, and with habilitation he has really improved. So typically children who have movements at the level of the upper limbs take a very long time to improve. When they don't have any fine scale movements of the hands, it takes a long time for improvement. Now again, these are toddlers with occipital gliosis. Both of them had hypoglycemia in the newborn period, and here the injury is confined to the occipital cortex. It's called occipital gliosis, and when you have a mushroomed appearance, it's called oliguria. So again, another child with optic ataxia brought, this is the same baby you saw in the picture, the baby aged 5 months who had no visual fixation or tracking. We corrected his visual problems, and this is, you can see the optic ataxia. So in the older child, again, you can test with the Lea puzzle or the Lea mailbox. They may have associated inferior visual defect. Some children may come to you with head tilt. Some may have photophobia. Again, look at the difference in the child after his vision has been corrected with glasses. So older children can be having high functioning CVI or low functioning CVI, like this child who was suspected to have a learning disability, and this is a child with whom Dr. Geeta had also seen. Again, he had features of autism, but it was because of CVI. Again, another child had moderate impairment with features of autism. We had to let her play on the swing, and only after which she came to our room for visual examination. So these are the diagnostic criteria. It's a diagnosis of exclusion, history of a neurological condition, presence of visual behavior characteristics of CVI, and eye examination. This does not explain. So it's a clinical finding. When you find abnormal neuroimaging findings like this, always suspect CVI. And when all of them had associated impairments in our series. The most common was seizures. You subject them to a detailed examination. Associated ocular impairments have to be checked, and you have to correct. This is a child who had balance syndrome with optic ataxia and oculomotor apraxia with simultaneous agnosia. So he's not able to shift his eyes. So these are some of the important references, and my many thanks to the Department of Pediatrics, GMC Thrissur, to the REIC, Department of Ophthalmology, Radio Diagnosis, and also to Dr. Maya Padmanabhan, who bought us the LIA tools for assessment. Thank you very much. Thank you for the patient hearing.
Thank you, Dr. Parvati, for that